I think that there was a dramatic change in the level of optimism about working with people with opioid addiction in the 1960s when Dolan Nieswander began using methadone to treat folks, and there were very positive results from that. But the cautionary tale is that some physicians naively and with good intent didn't really understand how to use that, and they came back here to Baltimore and started writing prescriptions for methadone in an uncontrolled way, and those methadone ended up in the streets in a way that created such a problem that the legal folks came to MedChi to ask what to do, and that started a process where MedChi tried to figure out what to do. My father was involved in one point running that process of trying to regulate the use of methadone. So here was an example where we finally had a breakthrough medication, and yet it was used in a way that created problems, and we're still living with some of the negativity of the misuse of methadone. And we then, in the 1990s, here in this town at Hopkins, we had some research about another agonist, buprenorphine, which seemed to be better than methadone in some respects. There was a lot of excitement about it. We finally got it 15 years ago, and indeed there was so much positive response that there was a lot of enthusiasm. But once again, there are people who have used this in a way which I think is unwise and has created controversy around the use of buprenorphine, and there's been some backlash behind it. So I think the cautionary tale is just because we have a tool that's effective doesn't necessarily mean that it's going to be useful. The important thing is how it's used, and I think that's what we're going to hear from Dr. Schottenfeld today, how to use this properly. I'm not going to say a lot about Dr. Schottenfeld. He certainly has very impressive credentials. He was, for many years, a professor at Yale, where he was teaching, doing research. He really pioneered in establishing both the addiction psychiatry fellowships and the addiction medicine fellowships, and trying to bring those together. He is now the chief of psychiatry at Howard University, so it's good to have another addiction specialist here in our area. There are a couple things that, without going through his whole CV, a couple things that stand out to me about him, aside from the fact that he was, for many years, the master at Davenport College, and I'm very jealous of that he could live with these students for all those years. That would be a very exciting way to come home from work at the end of the day. But he also, young as he is, has an honorary lectureship named after him at Yale in addiction medicine, and there are not a lot of people around like that. And so I think that's one notable thing. The other notable thing about him is that when I asked him what were some things I could say about him here, he said, first tell me about your father, because I'd like to have him in mind when I talk, and I think that speaks to what kind of person Richard is. So I welcome him to come up and tell us about what you can all do to help with the opioid epidemic.
Thank you, George, for the very warm welcome, and it's an honor to be here and to give Louis Kolodner lecture. So I did talk to George, heard a little bit about his father, and I think he's told him some of it. But I think that one of the key things is he was a general surgeon, and so he was a general surgeon who, in the OR, was very focused on the immediate problem. As he left the OR, and afterwards, he was thinking about all that led to that problem and all that might help in recovery afterwards. And I think it was that type of broader set of interests and concern that then led him to play important roles at MedChi. He was vice president, Baltimore Medical Society, where he was president-elect when he died at a very young age, mid-60s, and then also led him to get involved in that methadone crisis, the misuse of methadone. So I'm very pleased to be here and honored about giving this lecture. George also really, I think, alluded to one of the main themes that we all are aware of and we live in, which is that we go through wild swings of irrational exuberance about the medication, about a new treatment, followed by terrible consequences that lead to recoiling and a loss of memory about what was good about the thing in the very first place. That's eventually followed by a loss of that memory and an awareness of the wonders of that medication or that treatment, and a resurgence in its use, unalloyed and untempered by the experience. And it's those wild swings when we think about history. And one of my other mentors, and George and I talked about him, was David Musto, who wrote extensively and studied extensively the history of addictions, and the history of addictions in America, the American disease addictions, and in particular opiates, morphine, heroin, and the waves of use, misuse, and recoiling. And so we think about Bozeman behind the curtain there. He died in 1919. He spent his adult life as a physician during the period of time that there was the emergence of the morphine epidemic, of the opium and opiate epidemic, where there was wild overuse, and died, just before the period when the Harrison Narcotic Act was initiated. So of course, he saw only the harms. And of course, he saw only the failures of treatment. The other lesson that we all take, it's the humbling one from history, is here he was, just about the brightest physician in the world, certainly right up there, historic figure, who still had blind spots. He didn't see the potential for recovery. He didn't see the potential for cure. The humbling part isn't about him. The humbling part is, I'm always wondering, what is it that I believe passionately is fundamentally wrong? I, of course, think I have no blind spots until I get blindsided by a car that shouldn't have been there, but I want to keep that in mind. And I think that's all quite relevant to what I'll be talking about this evening. So that's my new institution. Delighted to be at Howard, also an historic institution. I don't have any conflicts of interest, nothing to disclose. And I want to talk about this evolving opioid crisis. What are the causes, consequences, the evolving public health response? What have we been doing? What effects does that have? And try to outline where we need to go. I'll touch briefly on this treatment work and what treatments are effective. I told George it feels a little funny coming to Baltimore and Maryland to talk about some of these things because, of course, some of the most innovative treatments and public health responses have emanated right here. But sometimes it's good to hear it from an outsider, so I'll do it anyway. And then I'm going to talk mainly about this gap between treatment need, the number of people needing treatment, and how few people get it. How come we have that gap, and what can we do to address it? And what can physicians do about the opioid crisis? What are the next steps? And I think about this, what would Dr. Louis Kalodner have done in this situation? What would he have educated him about? What new treatments would he have picked up to be able to address these problems? So this is the map. Maybe many of you have seen it before. This is opiate overdose deaths across the United States. In 1999, the dark red areas are the highest mortality mortality, overdose rates in the 20 to 35 per 100,000 range. That's 1999. That's 2014. So if you ever want to see a picture of an emergence of an epidemic, you could go through the time-lapse series and you could see that thing occurring, much as you might a flu epidemic in a season, but here over a number of years, 15. And it continued. The map looks worse now than it did back in 2014. So what happened? Oh, I think when we think about those overdoses and overdose deaths, for me it's always important to keep in mind, who are the people? Who's this affecting? And so I just went on the internet and I pulled a bunch of pictures of either people who had died of overdoses or people who had survived an overdose from opiates, just to think about it hits everybody. And at this point, this is an epidemic that it's rare that I can go any place that I don't meet somebody who knows, has a family member, a close friend, a neighbor who's had the problem. And it cuts across every socioeconomic, every geographic area, every racial demographic. So, of course, one of the big causes, and this is, I think, the first level of overexuberance, this is opiate prescribing for pain. From 1991 to 2013, and this is just the total number of prescriptions in millions written for opioid pain medications. And you see this extraordinary increase. And of course, it's the most well-intended approach. People were suffering with pain. We were under-treating pain. We really were. You know, anyone who was practicing 1991 knows it. I actually think that was a legacy of history of the Harrison Narcotic Act. Doctors were scared off about ever prescribing opiates, so they didn't learn to prescribe it appropriately, even for people who were dying of cancer. And after they began to treat people for cancer pain, then there became the notion, well, there are other people with severe pain who are disabled by it. Wouldn't they benefit? And then there are a few reports saying they do, they benefit. And in 100 patients, nobody became addicted. And then we hit our own version of irrational exuberance that was fueled by the pharmaceutical industry selling this as a safe, non-addicting formulations. And it ended up with this enormous overprescribing. And you just look at those maps, sort of graphs superimposed, and so it's opioid sales in green by kilogram for 10,000 people, the number of opioid deaths per 100,000, and the number of people going into opiate treatment from 1999. That graph ends in 2010, and I think you'll see the story, at least a big part of it. Okay, so what was our first set of belated public health responses? Beginning somewhere in the 2010, 2014 area, a number of responses locally, statewide in different places, and eventually nationally, trying to educate physicians and other healthcare providers and the general public about proper prescribing, about the dangers of opiates, addiction, increased restrictions on the prescribing and dispensing of opioids for pain, changes in treatment guidelines. So the pain societies and medical societies and JACO had been calling, pain was a fifth vital sign, and you couldn't allow somebody to be in it. People say, well, no, actually, people have to tolerate some amount of pain, and that is life. We should try to reduce it when we can, but not if we're going to cause damn problems in society. And the introduction of abuse-deterrent formulations of some of the opiate pain medications. So this just reminds us of some of the extraordinary measures that were taken, say, from the U.S. Surgeon General's perspective. In a 2016 letter, every physician in the country received a letter from the Surgeon General talking about opioid prescribing, prescribing opioids for chronic pain, asking physicians to take the pledge, to educate ourselves to treat pain safely and effectively, screen our patients for opioid use disorder, provide or connect them with evidence-based treatments, talk about addiction as a chronic disease, not a moral failure. Pretty extraordinary to send that out, get that message out. And then, just a few months ago, issuing a national advisory on naloxone, the importance of naloxone for opioid overdose reversal, the importance of getting it widely distributed so that people could get, families would have access to it. People who are using opiates would have access to it to administer it. So with that, be prepared, get naloxone, save a life, and encouraging physicians to prescribe it, or pharmacies to be able to dispense it without a prescription. Well, it sort of worked. It seems to be working. So this shows the map of trends in opioid prescribing, morphine milligrams equivalents, beginning in that peak of 2010, 2011, going down to 2016 on the far right, and there's a nice drop-off. So we seem to be curtailing the amount of opiate prescribing. Here's another way of looking at it. This is monthly retail opioid prescriptions on the top line, and below that, in high dose, more than 90 morphine milligram equivalents per day. And so you see pretty sustained drops, and this is over a year's period of time, so continuing drops. That's about the latest data that I was able to pull up. Doing a good job. So we're getting decreased overall opioid prescribing. We're also getting more medication-assisted treatment. That's the orange line, medication treatments for addiction, and some on that low bottom line is abuse-deterrent formulations. All good news. It is. But despite that, this shows the three waves of rises in opioid overdose deaths. And we're not seeing a drop-off yet nationally in overdose deaths. There are a number of factors that account for that. One is, you see various spikes somewhere around. The first wave was this prescription opioids. The second wave, some point around 2010, 2011, that orange line, the shift into heroin as an important cause of opioid overdose deaths. And then the last line, somewhere 2013, 2014, fentanyl, synthetic opioids as they hit. So the introduction of more potent opiates and more dangerous methods of abuse or use led to increases in opioid deaths. And that along with the shift into heroin, we were seeing a shift into a greater number of people using injection drug use. With injection drug use, one of the ways of looking at it, this just looks at hepatitis C epidemics and nationally reported cases that were pretty flat from 2006 to 2010, 2011, with that introduction or the resurgence of heroin and shift to injection drug use, shift in incidence of heroin and of hepatitis C from injection drug use, and in particular happening in people under age 30, which suggests that we have recruited a new generation of people into opiate addiction. So we've now talked about some of the primary prevention approaches, and they're very effective, I think, will be effective in helping decrease the numbers of new users. And we have seen some leveling off and decrease in the incidence of non-medical use of opioids over the past few years. But what they're not terribly hopeful with is when somebody's already become addicted to an opiate. And simply limiting the supply of prescribed opiates doesn't get them to stop. In fact, what it does, it raises the prices, and it makes heroin more attractive, and it makes fentanyl more attractive because it costs less to get in effect. And so I think we've seen from this a transition to heroin and fentanyl addiction in part, fueled because we had a large number of people who were addicted, and then as costs went up, they shifted to heroin. It's a story that other countries have seen other places. So the control of supply can be helpful, but it can also have this bad consequence. So I'm going to be thinking and talking more about some of the secondary prevention approaches, early identification of people who have the problem and interventions, and then how do we get the people who are addicted into treatment? How do we provide them effective treatment? So this is one of my favorite graphics because it tells the whole story that I always keep in mind about what happens to them when they become heroin addicted, opiate addicted. And so this is the 33-year follow-up of heroin addicts in California who were in the California Civil Addict Program. And the striking thing, when I find this graphic, is that there's a year by year, from 1956 to 1996, and you see that rising swath of black on the bottom, which is death. 48% died. Did somebody ask a question? 48% died during that period of time. They were in their 20s and their 30s when they started. Mortality risk for somebody, maybe 10%. If they weren't heroin addicted, they were getting a mortality risk that's maybe 3-4 times increased. Also of note in there is almost no methadone maintenance treatment. Came in late during this, and it wasn't made widely available. So this is in words what the picture says. 48% died. The deaths were mainly due to opioid use disorder. There was an incredible persistence of the addiction after the onset. Very few, less than 20%, achieved anything approaching long-term abstinence or recovery. One-sixth of those using the 20-year follow-up were abstinent 10 years later, so very unlikely. Then of particular note in terms of the relapse risk is a sixth of those abstinent for less than 50, or only 1 out of 6 of those who were abstinent at the 20-year follow-up were abstinent 10 years later, if they've been abstinent for less than 5 years. And really scary is about a quarter of those who were abstinent more than 15 years at that point relapsed over the next 10 years. So if you want something that makes you remember this is really a chronic, nasty disease, that when you have it, you gotta live with it and be in recovery for the rest of your life. These statistics, I think, tell the story. Okay, maybe that was just 1956, that people were dying so fast from heroin addiction. Maybe we could just detoxify people and put them in a short-term residential program and they'll do well. So, there are a slew of more recent studies. I pulled this one. This one's from Ireland. I like this one because they had people in a 6-week residential program for heroin addiction. And then looked at what happened to them. They enrolled them, 149 patients, and the very first thing that I put in notes in black is that 5 of them died within the first 6 months. So we're still getting terrible mortality risk. In fact, when you detox somebody, when you send them out on the street, they're at increased risk of dying because they're not tolerant to opiates. If they use what they used to use, they're going to overdose and they're going to die. And of course, that happens if you come out of prison or jail. Big risk points. And then you look at the graph, shows the relapse rates. And it shows this overall rate that 94% of the ones they were able to follow
had a lapse, over 90% relapsed within the 6 months of leaving treatment. Over 90% relapsed. Most of it happened very fast within the first week. Those statistics actually paint a rosier picture than the reality, because if you look at, they were only able to follow 103 of the 149 people. What's your guess about the 46 that they didn't follow? You think they were all abstinent? Do you think any of them? So I think their actual relapse rates were even higher than this. So that means so what treatments are effective? And here I won't spend much time talking about how medication treatments for opioid addiction work. I'll just sort of quickly summarize the 3 medications that are out there, that are approved, that we know work. Methadone, which has now been in use since the mid-1960s in this country as a treatment for heroin opiate addiction. Buprenorphine, which got introduced in about 2001, 2002 as a treatment. And then most recently, this long-acting injectable formulation of naltrexone, Vivitrol, that once-a-month injection provides relatively good continuing opioid blockade. All 3 medications are approved by the FDA, have evidence of their efficacy and effectiveness. I'm coming to Baltimore to say, so what happened in Baltimore during the 1995 to 2009 period when buprenorphine got introduced and got scaled up, and what happened to opioid overdose deaths in Baltimore? And the red is the deaths, and it plummets, and the bottom line, green dotted line, is the increase in the number of people getting treatment, predominantly with buprenorphine, and the top one is the other dotted line is methadone, number of methadone patients. So there was an increase in both. As we scale up treatment, we can reduce consequences. It's an effective, both of them, effective treatments. It wasn't just Baltimore. That one looks at what happened in a slightly earlier period in France when they introduced and scaled up buprenorphine treatment. So when people get addicted, they need treatment. And these treatments reduce overdose risks, have a big public health benefit. And then this is a meta-analysis, graph from meta-analysis looking at medication-assisted treatment, methadone treatment for reducing HIV transmission, and in the solid line going, that vertical line in the middle is no benefit, and anything to the left of it says it reduces the risk. And so all those studies reduce the risk, which every single one shows an increased risk overall, a strong decrease the risk of HIV transmission when people are on methadone. These treatments work. I'll only mention one of the more recent studies about what about extended release naltrexone, because it's useful to think about that medication and what its place will be in the treatment armamentarium. So this is a community-based study. 8 community-based inpatient, outpatient programs. Everybody got detoxed in an inpatient setting, and then they were randomized either to Vivitrol or to buprenorphine for 24 weeks. The detox programs, as you might expect when you cut across communities, varied. Some of them were really short, some of them were long. Overall, across the sites, first difference was about 3/4 successfully initiated Vivitrol. About 94% initiated buprenorphine treatment. So getting people on Vivitrol was harder, and we may lose. Some patients aren't going to make that transition. More of them won't make it. If you overall look at the intention to treat, everybody who got randomized, which is the fair way to evaluate the clinical trial, you see some difference that 65% of the Vivitrol patients versus 57% of the buprenorphine patients met the relapse criteria. So some benefit, a little bit, of buprenorphine overall. But when you look at people who got inducted, completed induction, the relapse rates were similar. So it suggests that, at least with patients willing to go on Vivitrol, so these were all patients who volunteered to go on one or the other, if you can get them on it, they'll do about as well as they will in buprenorphine treatment. Okay, so here's really some of the key things that I wanted to focus on. We've got good treatments. They make a big difference. They save lives. How are we doing at getting those good treatments to the people who need them? And here, I think we're in the midst of a national disgrace. So when we look at 2016 statistics, 2.6 million, this is an underestimate, need treatment for opioid use disorder, about 600,000 for heroin. 1 out of 5 received it. What would we say? We said that 3 million patients with treatable cancer in the US, and we only treated 20% of them. We wouldn't tolerate it. We'd figure out a way to make it better. It's just the same, different view of it. 20% get treated for an opioid use disorder, and that's any treatment. That's not even looking at effective treatment, because remember, 2/3 of drug treatment programs in the country still don't use medication treatments. Where do they get treatment? Prison, jails, emergency departments. They don't even get expert care, primary care with people who know what they're doing. So it inevitably raises the question, why are we so bad at this? And what do we need to do to make it better? So I know, I don't know what anyone else's experiences were, but I admit that through my medical school and frankly through my psychiatry medicine training and most of my psychiatry residency training, I believed what Dr. Osler believed. This was an incurable disease. In fact, I wasn't even sure that addicts cared whether they lived or died. I mean, after all, if you cared whether you lived or you died, why would you inject heroin? Why would you share needles? Why would you do all those things? That's myth one. They don't want treatment. They don't care whether they live or die. We have plenty of evidence to show that's just not the case. The beginning of the HIV epidemic, what brought it home to me in New Haven, we saw this huge surge in HIV among our patients and methadone coming in for heroin treatment of HIV infection. Before we did much other than to publicize that it was risky, we saw a sharp downturn in the number who were injecting drugs. They shifted to a safer mechanism. They wanted to get high, they couldn't not use. They didn't want to get HIV. They didn't want to die. Okay, the tube treatment doesn't work. It does work. I'm not quite sure how best to counter that prevailing view. Stigma, that keeps everybody out, keeps docs from treating patients well. It keeps patients and families from coming in. The connection, mistrust of what we're going to do if they tell you that you're an addict. That they'll be thrown out of your medical practice if you're a general practitioner, or lock them up. Somebody, fear, shame, and our own attitudes. If we only see people at their worst moments, if we don't believe that anyone with a heroin addiction or opiate addiction can recover, not the most welcoming face or most encouraging people to consult. Most of us, I think, try to say, here's how things are going to get better to be effective. So I know one of the things that we faced when we tried first to expand our treatment programs, I went up to the state legislature and argued, give us more money, we need to treat more people. You know, a small waiting. So we have a small waiting list, we can cover your 40 patients, add 40 patients, but actually drug addicts don't want to come into treatment. And we have to counter it with the question, you know, if we build it, will they come? Can we create programs and approaches that engage people and bring them in early, and will that work? And I was very much affected by, came out of a family that was in business, and so I always thought, oh, how does a successful business work? You know, you think about McDonald's with one lonely hamburger stand in 1946. Did McDonald's say, how many people want a McDonald's hamburger and we'll keep our one store? They said, what can we do to get people to want it? So we make it available. We make quality, ensure high quality, attractive product. We make it easy for people to get. It's located nearby, it's convenient, they don't have to wait. Make it affordable. It doesn't cost a lot. Be friendly, welcoming when we engage, when people come in. And we publicize it. We do things to market. We try to address the issues of stigma out in the community. That's the model that Amazon uses. That's the model that hotel chains use. That's the model that we need to be using. Will it work? So we started looking at strategies to first level to say, how do we expand our treatment system? And how do we engage more patients in treatment? And could we bring people into primary care? And you know, we were motivated by thinking we got to increase the number of physicians treating patients for addiction, able to do it. We need to increase the number of sites and locations. I knew I was never going to be able to build enough drug treatment programs to be able to treat all the people with heroin addiction. My gosh, it was nearly impossible to open a second one in New Haven. People don't want drug treatment programs in their community. But they're very happy to have a primary care doc or a clinic in their community. And if that person is treating high blood pressure and treating cardiac and diabetes, and happens to be treating addiction too, they're still pretty happy to have primary care docs there. So we thought this was an important strategy, facilitate access. A lot of the patients were already seeking primary care. They were seeing docs in all these settings anyway. It reduced the stigma, and we'd be able to coordinate their treatment. Since he's sitting in the front row, I got to tell you, when we talked about this idea with a guy who was then the head of CSAT, at a CPDD meeting in Chicago or something like that. We were sitting down, and you know, he knew it's not like my idea to try to do this thing, but he was like, well, how are you going to do that? What, you know, and I said, well, you know, 1994 or something like that, 95. I said, well, let's try to offload methadone patients, get methadone into primary care. And great, you know, there are a couple of pilots. Let's get a study. What could you do as a study? So this was the easiest study we outlined over lunch. I scribbled out, and I said, well, this will randomize patients to primary care offices, you know, general practitioners, and we'll compare them to the ones who stay in methadone. We'll see how they do. They said, great. How much is it going to cost? I can give you up to this. It wasn't very much, but it was enough. And so we did it. That was our first primary care project. And we learned a lot. The first thing we learned is that we could go into, we did it in Waterbury, couldn't do it in New Haven because nobody would have believed that it had any relevance to the rest of the world. But Waterbury seemed appropriate, and we lined up 7 general internists in office-based practice, family docs in office-based practice. It wasn't that easy to get them. And I remember one of the docs, we were talking, what are you worried about? I said, I'm worried. I got all these addicts coming in. They're going to steal the television set from my waiting. I said, come on, I mean, they're already seeing you. She said, oh, you know what I mean? So you just don't know about it. So that was one of the docs who signed up. We talked to patients. And the patients, they were really interested. So it sounds great. One of them said, as long as you don't tell my doctor. I said, why shouldn't we tell your doctor? Your doctor doesn't, of course not. My doctor would never understand that I'm on methadone maintenance. He thinks I work and I'm a good person. If you told him I was on medical maintenance, it would ruin our relationship. He said, well, how would you feel if I told you that your doctor has signed up for this project and wants to provide medical maintenance in his office? I said, what? So this misunderstanding, was that little way. Anyway, that's my story for Jerry. That was our first study. Out of that, we developed our training programs. How are we going to train docs who don't know anything about opiate addiction? We came up with an 8-hour training program, a core set of modules. We then used it when we moved into our buprenorphine projects. And then David Feline helped bring it back to CSAT and became part of the core of buprenorphine training programs. I think that's why we were stuck with 8 hours, because we did 8 hours of training. Okay, so I'll go through a few of the things that we've done since then and other people have done just to think about where we're moving on this. So that was a great success. Patients did just as well in physician offices as they did in the methadone program. They really liked it. So it was safe, it was effective. It failed the last test that we set, which was scalability, because we just couldn't figure out, it was too cumbersome to make methadone work at that point in primary care offices around the country. So at the same time, we, along with a lot of people in Baltimore and Philadelphia and a couple other places, were doing a lot of work on buprenorphine that we thought of as an alternative to methadone. And as we were doing that work, we started using it actually a 3 times a week schedule. And we said, gee, maybe buprenorphine would be okay for primary care. People are like, well, we're so happy we'll have to come in 3 times a week. It'll be like going to some office for dialysis. It'd be terrible, but it'll be better than maybe make it easier. And then as we got close to doing our primary care study, it actually looked like, because of its potentially lower abuse liability or overdose risk, that it might get eventually approved for more general office-based use. So we looked at buprenorphine naloxone maintenance for new patients coming into treatment fresh, not from a methadone program, in a primary care clinic. But we want to know, is it feasible? Is it safe? Is it potentially efficacious? And we also wanted to look a little bit to figure out what type of counseling, because there's not a lot of behavioral health services or drug counseling in those settings. So we did it as since we were getting funding from NIDA, we did it as a randomized clinical trial, and we compared 3 levels of behavioral counseling. One was just physician management. So, providing and prescribing physicians saw the patient every week for a few weeks, and every couple of weeks. We did it in 15, 20-minute increments, where they got that, plus nurse-delivered additional medical management or some enhanced nurse-delivered treatments. We're really looking at scalability. So the neat thing about it is, this is a slide that just looks at opioid use. This is reported days per week across all 3 groups. And so they came in and they were all using all the time. And that's that top left, and then opioid use, this is then week by week at the 24 weeks. And there's an enormous sustained drop-off in opioid use and no differences. So these 3 levels of counseling didn't affect outcomes in this. What we sort of looked at, so, well, what did they think about coming into the primary care clinic? We just pulled a few things that they said. No one knows why I'm here. No one knows I have a drug problem. That's really important. We had a school teacher come into that. 20 years, heroin addiction, never been in treatment. And what she said was, how could I go into your methadone program? There are only 2 reasons for somebody to show up in a methadone program every day. Either you work there or you're a patient there. Since I'm a school teacher, if I went there and the parents of one of my students saw me there, they would know I wasn't working there. So I'd have to be a patient there. I couldn't risk it. I'd lose my job. But primary care, I come in. Nobody knows why I'm here. I could have high blood pressure. I don't have to be around junkies. It turns out that addicts have the same attitudes that everyone else has about other addicts. I like talking to the nurses. I only have to come in infrequently. They only have to come in 3 times a week. That was a real improvement over daily. It's gotten better. We also looked at sort of patients who are coming into this project versus those coming into our methadone programs at the same time, just to see we're just drawing on the same set of patients. And actually, no, we were tapping into a population that was a little less likely to have had prior treatment. Many of them had never been in methadone treatment before. They were earlier in their courses of opiate use disorder. They were a bit younger. They had lower rates of injection drug use. So we were catching them, beginning to get to a population that wouldn't come in to a methadone program until later on. So this was really promising beginning. And of course, other people finding similar things, and then buprenorphine got introduced, and this shows then just what it's meant in terms of expanded access to treatment. And so what we see here is that the bottom lines, there's a steady line towards the bottom, which is number of that's the, this line is past Europe. Not much, but okay, I've got already pointed. Anyway, it shows an increase in the total number being treated with either methadone or buprenorphine. So there's a big increase in the total number. The flat line at the bottom says that that increase isn't from methadone, more or less the same number of people being treated for methadone. All of the increase in the number of people being treated comes from the expansion of buprenorphine. And the top line is the unfortunate line. As we were increasing access to treatment, the epidemic was roaring. And there were more people becoming addicted than our treatment increase was picking up. So had we only stayed back where we were at about 2000 with the total number of people, we would have gotten pretty close. But we didn't get anywhere near close with the epidemic occurring. All right, so then we've looked at some questions. That first study with the nurse-delivered counseling didn't show much of an impact. And so we said, well, what about more professional or more focused drug counseling? And fortunately, we did 2 studies more or less at the same time, one in New Haven and one in Malaysia, because we were doing some international studies. The one in New Haven, we did back in the primary care clinic. We randomized patients, got them all on buprenorphine. They got randomized to buprenorphine with physician management, similar to what we had, or with CBT provided by well-trained psychologists. A 12-course set of CBT lasted for 24 weeks total. And then in Malaysia, what we did is with a different setting, different patient population, we took 2 really busy general practitioners in their private offices, and we put the patients in. We did assign them to different things, just seeing the general practitioner with their physician management, or they could get some additional nurse-delivered behavioral counseling. It was very much contract goal-directed, very concrete plans, or they could get physician management buprenorphine and abstinent contingent buprenorphine. If they got regular buprenorphine and just got it every week, supply to take home, abstinent contingent take-homes meant that they had to be abstinent, had to have a negative urine in order to take home the buprenorphine. Otherwise, we administered it 3 times a week in the clinic. Or the combination of that behavioral counseling plus abstinent contingent buprenorphine. Okay, so you wish that science always precedes the same results in the same, similar types of studies. The New Haven study says the CBT didn't add anything. The Malaysian study said, hey, those behavioral interventions made a difference. Both of them. And combined, they made the best. So providing that directed counseling, providing some contingencies, using how often they have to come into the clinic in order to get their medication, or combining a combination, improved over, they're not terrible results. I mean, everyone did better from baseline, but improved over physician management alone. So what's going on here? And this is actually, I don't have the full answer. I don't know for sure. My sense is that what this suggests is that whether behavioral interventions make a difference may have a lot to do with who the patients are, what they need, and what your standard providing them in your standard practice. So I like to say, since I'm a big believer in behavioral counseling as an important part of this, that, well, you know, if you get Dr. David Feline as your primary care practitioner in 15 minutes once a week, providing you buprenorphine and a lot of education and encouragement, he can do a really good job. But if you don't have him, maybe, you know, in the docs in Malaysia, they were very good. They were really busy. They did not have a lot of time. So they really stuck at best to the manual of how often to need they did it. But so some of it's at who the patients are, what they need, and what we're comparing it to with the level of services in comparison. And in practical terms, I think what that means is that there is no one size that fits every patient. In some patients, if you can get them on medications, that's it. They run with it. They recover through their own processes. They engage, they get back in with their family, with their old friends, and with the monkey off their back and not being buffeted by craving and withdrawal, they do great. And others need more than that. And our goal ought to be to figure out which one's minimal and which one's more, and there are a variety of approaches that allow us to do that. Then people, you know, some of my colleagues up in New Haven did something which Maryland, I think, is very familiar with because they expanded it throughout Baltimore and the state, which is initiating buprenorphine in the emergency department. So, you know, people so they inducted people in the emergency department and started them on buprenorphine, some on buprenorphine. It was a randomized trial. They did either just referral for treatment, a brief intervention, or the intervention plus emergency department initiated buprenorphine. A couple of things to note in terms of who the people were. Almost half used the emergency department as their regular source of care. So that's where they were getting care. They weren't seeing a primary care doctor outside of there, which suggests this is a really important place to be getting people into treatment. The second is only about a third were seeking treatment for opiate use disorder. 2/3 they had to screen, identify opiate use, and then engage in treatment. But they did. They came into treatment. So the asking was possible to do, and they got them to come in and agree to this study. The primary outcome is that if you start buprenorphine, you get much better follow-up in treatment 2 months later, in 30 days and in 2 months. 78% of the emergency department patients versus 37%, 45% of the other two groups. So you get something out of the referral, but you get a lot more to start people on medications than arrange for immediate follow-up. And there was no differences in those who were coming in saying, I need treatment for opiate use disorder, heroin addiction, than for those who they identified through their screening. Again, good reason why we need to be screening. Then they did a longer-term follow-up, and the results are significantly different at 2 months. But by 6 months, the effects have faded away. And, you know, by 12 months, there's no significant differences, you know, between groups. And the other thing is about half overall of the patients are still engaged in addiction treatment. So this brings me to then what I think is the next challenge that we face. We face the challenge, how do we get more people into treatment? And then we face the challenge, how do we keep people in treatment once they start? Because these treatments work while people are getting them, and they don't work when they leave. And again, growing up in a few that patients came to me in my office. And if they didn't want to come, they didn't come and they left. And, and now I very much think that we need to be figuring out strategies. How do we engage people, keep them engaged in treatment? And so I'll go back to that really positive findings that we had in that primary care buprenorphine study. And I'll try to point to the bottom line, which may or may not be visible to everybody. But this is the number of patients, people, who were still in treatment at each of those time points. I'll take a question just after I finish this. And what we see is a pretty big, we saw a very big drop-off. Yeah, okay. Back? Sure.
The question was in 2006, were they self-reported clean or drug tested?
In 2006.
That's the data that you showed us was from 2006. The studies were performed in 2006.
Oh, you mean so the original primary care study?
Yeah.
Oh, no. I showed you the self-report data. We had urine toxicology data. It was very consistent.
Back in that day?
Yeah. And clean, for a funny term, it's either absent, just because it potentially plays into clean, dirty, and what our metaphors are about people who have substance use disorders or who are addicted. But the other part is that their urine toxicology testing showed a dramatic decrease in the amount of use. Not every person who said he didn't use it all never used in there, but they all dramatically, very, very much reduced their use. And from a safety standpoint, this is really glad you asked the question, because when we think about what we're trying to achieve and what's a good outcome, which is what as physicians, healthcare providers, we always need to be focused on. I have one central thing in mind. That's that graph, the 33-year follow-up of heroin addicts, and it's that black swath. So I care about lots of things, and I would like to see everybody live fabulous lives. But I want to make sure that everybody stays alive for as long as they possibly can. From a mortality risk, you get several things on buprenorphine. They dramatically reduce even if people don't entirely stop. And while they're taking the medication, their overdose risk is dramatically reduced if they do use. So you hit them in two ways from an overdose risk prevention. That you reduce their likelihood of using substantially, and you substantially reduce the risk that any time they use, they're going to overdose. So it's not a perfect treatment, and it doesn't mean that somebody starting on it won't ever use again. People like to get high, they want to try, they run into old friends, it's their birthday, it's a friend's birthday, but they'll shift. Many will stop entirely, and many who do extremely well will shift into a pattern where they rarely use, but they still occasionally use, but it doesn't ruin their lives. So, and this is important when we think about what should you do with somebody who continues to use. My sense is what we should do is keep them on the treatment and figure out how to make the treatment work even better. But one of the disasters that we've created is we've been so worried about diversion, misuse, that as a field we've thrown people out of treatment because they use. We use the diabetes analogy. Most docs wouldn't throw a patient out if they cheated and eat desserts, or they don't follow their diet. Their hemoglobin A1C is as good as it should be. They'd say, hey, we should try to help you do better. It'll make a big difference. But go ahead and stay in treatment. Because if you don't, you'll get diabetic ketoacidosis and you'll die. Okay, so I'm going to wrap up. I'll tell you some of the things that we're just beginning to engage in. I've been thrilled to move now to new terrain, to Washington, D.C., where there's plenty for me to do. It's quite exciting. I was particularly pleased to come up here because for some eager to collaborate, establish collaborations with people in this room, at Hopkins, at the University of Maryland, and I think with primary care practices. We're doing a couple of bits of work, and other people are looking at it. What are the ways that we can do even better getting people into treatment? So how do we step outside of the medical encounters to engage people? And so we're beginning a project in Wards 7 and 8 in the district, looking at, so what are the community organizations, the non-medical, non-traditional resources that might be good for identification and potentially even low-threshold treatment initiation? And so I borrow shamelessly from, say, studies of hypertension in black barbershops. Turns out that's a really good place to engage black men who are very high risk of high blood pressure and treatment for blood pressure. And actually, if you have a pharmacist doing the prescribing, you can monitor and you can get pretty good treatment outcomes. That may or may not be the best place to engage people in addiction treatment, but we ought to find that. And if not there, how about in some of the housing groups? How about some of the church groups? How about some of the social service agencies? And so we're looking at, a part of that is also to be able to try to identify. So how do we address stigma in that community, in different communities? What are the sources, and how do we overcome the resistance? Stigma about the disease, stigma about the treatment. And then we're also very engaged in developing sort of established collaborations with Unity Health, which is the sort of the largest federally qualified healthcare set of clinics. I think they've got about 40 clinics in the District of Columbia, treat about 100,000 patient lives, virtually all on Medicaid or uninsured. And so we've established collaboration with them. They're very interested in buprenorphine treatment. They have a physician champion. They've trained up docs. The CEO is very supportive of these efforts. And so we've established a collaboration with them to figure out, so how do we use an integrated collaborative care model to bring some of our additional addiction and psychiatry expertise and resources to help improve services there. There are other studies, I think, we're not the only people there, but this is a really important area that we need to be looking at. How do we engage more people in treatment? How do we keep them in treatment? This latter is keeping them in treatment. Part of that is how do we develop peer recovery resources? Peer recovery coaches, people who are feeling comfortable going out in the community, somebody doesn't show up, and say, I think I can find them. I think I know somebody who knows them, who will encourage them to come back in. We use text messaging to do that. What are our technologies and interpersonal approaches, and social approaches to engage and retain more people in treatment? I won't trade much on this, but decrease barriers to get people in treatment and increase treatment. We did this in our methadone programs in New Haven. And we said, well, 2006, our waiting list, it was at least 21 days on average to get into methadone. We got to be able to do better, and we got it down to less than a day. Anyone calls up or shows up, up until about 3 o'clock in the afternoon, maybe 2, on any given day. They call up in the morning and they say, where can I get treatment? Come on over. And they can start either methadone or buprenorphine that day. It's impressive. It took a lot of sort of engineering to do it. That's what happened to our patient census, which also took a lot of engineering to figure out, oh my goodness, if we build it, will they come? Yes, indeed. Now what are we going to do with them? How are we going to provide them good treatment? How are we going to adapt the treatment models to be able to do that? But I can tell you that the overdose death rate in those 4,000 patients is virtually nil. You know how our methadone patients are dying? Because they do die. Heart disease, pulmonary disease, diabetes. They die of all the medical conditions that people, as they age, in particular if they've lived unhealthy lifestyles and smoked cigarettes, get. So we need to be addressing those. But We've had a big impact there. This is sort of the model. We need to engage more people in care. We need to get the people who need it into medication treatments. We need to keep them in those treatments for a long period of time, until they're very stable or lifelong. It's an approach that has helped us with the HIV epidemic. That's the 1990s. We're going to find 90% of the people who are HIV infected. We're going to treat at least 90% of them, and we're going to get viral suppression in at least 90% of them. We ought to be having targets of not we treat 20% of the people with opiate addiction, but we treat 90%. And other countries do it, so why can't we? We can. And we ought to be holding them in treatment. We ought to be getting them to the point where they're doing really well in treatment. So what's at stake? As I was cleaning out my office in New Haven on the move to down here, I found in my files a really painful letter that I got from the mother. My son's now dead, thanks to the doctor at the local hospital emergency department. They should know at least as much as police. My suggestion is to educate hospital emergency room personnel regarding drug abuse. Right now, they're the last people to go to for help. And then she ended with this poignant quote from Eric Erickson: "Death like this does not retreat into some discrete compartment of the mind, emerging now and again to haunt one's dreams. It remains with one, becoming a part of the very air one breathes, and a dominating figure in one's imagery." That's what motivates me. It's what motivates, I think, all of you. We want to try to prevent that as much as we possibly can. We've changed some things for the better. We've got a lot more that we can and will do. So I'm going to conclude, and I was sort of thinking, since I came up with the title, what can physicians do? I was saying something, and I thought I went to another obituary. This is the mother eulogy for her daughter. It's not always possible to comprehend the level of suffering that others may be experiencing. And I know when I encounter patients, that's what I try to bring with me. I have all my defenses ready to come out. How do I get to feel their suffering so that I treat them, connect with them as another human being who's struggling with issues and see their pain? Appreciating the suffering of another person encountering stigma. They're critical for the work that all of us do. And I think our role is then to provide accurate diagnosis. Figure out who's running into problems. Identify it early. Refer them early. Start treating them early. Intervene. Give them good advice, guidance, treatment, and support them through their recovery. Don't give up on them. Hold out hope. That's what our calling is. And when we do that, we can be enormously